This is going to be a training in the best dementia care, the basis about Alzheimer's and other related dementias. And I'd like to also thank the first responders. We appreciate you all very much and what you do. We know your job is not easy, and we definitely are grateful and appreciate everything that you all do. I'm going to go over our services. So this is with the Alzheimer's Alliance of Smith County and also the East Texas Alzheimer's Alliance, which is in Longview. We have very similar services. Here in Smith County, we have personalized case management. We have a social worker, Maggie Edwards, who works with people. And when I say case management, once somebody comes into the Alliance, there is a relationship that is built, and it continues throughout their journey. And it's a difficult journey. Any of you all out there that have cared for anybody with Alzheimer's or other related dementia, you are my hero, because that is one of the hardest caregiving jobs that you can have, whether you get paid for it or whether you're caring for a loved one. We also offer free memory screenings. We have a lot of caregiver resources. Jamie, who you met a while ago, is our director for Day Club. And I know some of the officers have attended our Day Club, and we appreciate them when they come. We have some that dance with our Day Club participants. We have support groups. And we also have a licensed professional counselor. She's an intern. She did her internship with us, and she did such a good job. Her name is Kathy McCabe. And she counsels a lot of caregivers. And I want to say how important caregivers' health is, because caregivers don't take care of themselves. It becomes 24/7. And I had a gentleman that his wife had Alzheimer's, and she was early onset. So she was in her late 50s when she was diagnosed. And when he finally came for help, he had not been to his doctor in over 5 years. And so we want to make sure that they have the resources, that they can go to the doctor, go and, go get a haircut, go to the grocery store, do those things that we all take for granted when we're not caring for somebody. And Kathy really helps with the grieving process of this disease. And we always say that people grieve twice when you're caring for somebody with dementia, because you're seeing that person change of who they used to be. And because they are in brain failure, we're seeing a lot of changes with their personality. So there's a lot of grieving that goes on with that. So we really appreciate what Kathy does for our caregivers. We're going to talk about the Project Lifesaver bracelet. Gene Saunders is going to talk about, he developed it and why it's important. We have a lot of educational seminars and workshops. I do the physician outreach. It's been a little limited recently because of COVID. And we also will do home visits. Again, that's kind of limited right now because of COVID. So as you know, our brain is our most important organ. It is our brain is in our destiny of our hands. It's basically our memory, our mood, ability to think, strategize, imagine, forge relationships. It's the personality that we have. A lot of people will ask me, what can I do to take care of my brain? And I really relate it to heart health. Heart health is brain health, and we want to definitely, the Mediterranean diet is a very good diet. It's easy to follow. It's basically, fruits and vegetables, lean proteins, try to stay away from sugars as much as you can. And we're going to be talking about some of the different dementias and how heart health can affect some of these dementias out there. So we know that as we age, and I put this in here because this is my generation. I used to watch Happy Days, but we can see that we get gray hair, we start losing some hair, start getting a few more wrinkles. So normal aging, we can see that as we get older, we can visually see that somebody is changing and that they're, I like to call them seasoned. I'm a seasoned adult, but we can tell that that we're aging, but what's going on in the brain? And that's what we're going to talk about today. Normal versus not normal aging. So if I don't get a good night's sleep and I'm trying to find the right word, I might call it a thingy. You know, that thingy over there. Well, nobody really knows what a thingy is, but sometimes we'll struggle to find the right word. That doesn't mean that I have dementia or early onset Alzheimer's. It just means that maybe I didn't get a good night's sleep, and that's affected my cognition a little bit. And also stress can do that too. We are slower to think. That is normal. As we get older, we may hesitate more. We may know the person but have a hard time finding the name, and that happens to me quite frequently because I meet a lot of people. They look familiar, but I can't remember their name. May pause when we're word finding. So what's not normal is unable to think the same, unable to do, excuse me, what we used to be able to do. We'll get stuck in the moment of time. And I also like to use the word time travelers. When people get stuck into past and present, confused about what really happened in the past. They may know the information really, really well, but they may get it kind of confused with the present, and we kind of call that confabulation. And they kind of travel between past and present. Words won't come even with visual, verbal, touch cues. Unable to successfully place a person. Unable to think things out. This is a big one. Personality and or behaviors will be different. So that person's personality is really changing. And I also want to state that our working memory peaks at the age of 25. Okay, so just because it peaks at age 25 doesn't mean that we can't continue to learn new information. It's just that's when it peaks. And that's why I'm always in search of a young person to help me with technology, because they can pick up on that really, really quick. I really need a young person to help me with technology from time to time, because it's really amazing how they pick up on that technology. Things that mimic dementia is depression. And so when you think about somebody who's depressed, and we've all gone through periods in life to where our mood is depressed, we're unhappy of a death, we're struggling with just things that happen in life, and maybe don't get enough sleep. This can affect the way we think. We may just feel like, it's just not worth it. Loss of functions, mood swings, not wanting to get up out of bed, sleeping too much, personality changing. People call and say, hey, would you like to go and have dinner tonight? No, I don't feel like it. They just don't have the energy. And, if you all know somebody that's experiencing depression, they need to go get some help, because this can really affect their cognition. And the other thing is delirium. And delirium really happens a lot with the elderly, especially when they have some form of dementia. And if you put a urinary tract infection along with somebody living with dementia, they are going to be have some hallucinations. They're going to have a lot of anger. From time to time, their personality is really going to change. Usually delirium is temporary, okay? Usually we see this in the hospital. If somebody comes in with a urinary tract infection or pneumonia, they have an infection, antibiotics can usually bring them back to their base. People living with dementia, sometimes that's enough to cause them to have a shift in cognition. So that is something to think about if you all are dealing with anybody who are caring for somebody that's got dementia and has a urinary tract infection. You definitely need to get to the doctor and get on some antibiotics. And the other thing, as people, especially women, we have a smaller urethra. And so, if we become incontinent, there's a hygiene issue there, which puts them more at risk for getting a urinary tract infection. So those are just things just to be aware of. So there are drugs. Yeah.
We had It's from Melissa Drigger. She says, I resonate with this being an EMS. I can't tell you how many phone calls we get from family members who call 911 because they don't know what else to do. It is heartbreaking.
Oh, I know it is. And Melissa, do you all, I guess you take them to the ER then, right?
We'll wait till she, go ahead, Luann.
Okay, yeah. Well, and usually that's what happens is they go to the ER and, the ER will either send them home with oral antibiotics, but if it's an infection that's in the kidney, then, or, severe enough to where they have flank pain, then they will admit them to the ER. But a lot of that is education. And, something that you all might be able to recommend is if you have somebody and you go to their house, is recommend they go to their primary care doctor and maybe have home health come out. And then that home health nurse can do a urine culture from time to time, and it keeps them from having to take them to the doctor all the time. And so, that's something else that you could do is recommend home health, and they would have to get an order from their primary care doctor. And the primary care doctor usually has a couple of home health agencies that they work with, and very seldom will a doctor not, write an order for home health for somebody who's living with dementia. So there are drugs that affect cognition, antibiotics, antihistamines. I'm going to also say Benadryl because I'm somebody that really needs a good night's sleep, and I was using Benadryl to sleep at night, and I get all these memos and research on brain health, and Benadryl is not a good drug to take for a long period of time. It's okay, for situations, allergies and stuff like that, but not a long period of time, as far as taking it to sleep. So anyway, I'm not going to read all these off because you can see them on my screen. But, one of them that's really interesting is the Anti-Parkinsonian Agents. So I'm going to be talking a little bit about Parkinson's later on in this presentation. And so those drugs can cause cognition issues. So it's that, benefits versus the risk. Some clients prefer not to be on these agents, but if the shaking and the rigidness is too much of a problem, the downside is it can also affect cognition. So I like to put this in here because we're in the world of technology now, and we are outsourcing our brains to our smart devices. And the reason why I brought this up is I really worry about our young generation who are constantly on their phones and aren't socializing. They're socializing through social media, but they're losing that ability to have a conversation. And we know from research that that brain health is forging those relationships and having communications with people. That is part of brain health. As soon as this COVID is over, I'm sure a lot of people are going to be out doing all types of social things, which is really good for your brain health. Today, listening to me speak, I'm trying to make this as interesting as I can, is good for brain health. Hopefully you're going to learn new things. But I will also say that we can only manage 5 to 8 things at a time. So some of us may call that multitasking, okay? So I'm here giving you all a presentation. I have my phone put away. Now, can you imagine my phone goes off and I try to read a text message? I can do both, but I'm not going to be able to do this very good because I just reset my brain to look at something else. So we say we can manage 5 to 8 things. That's what the research says. But the other thing too is, I always like to challenge people. How many phone numbers do you know now? I remember back in the day when phone numbers had letters, and ours was 2B2 or something like that. I can't remember my home address, but there was one time, or home phone number back when I was 5, 6 years old, that I could remember. I can remember my parents' home phone, okay, which they still have. And I can remember a couple of others, but we are truly forgetting to, memorize our phone numbers of loved ones. We're depending too much on our device. If we don't have our device, do we have those phone numbers somewhere else, or are they just all in our digital device here? So anyway, it's just something to think about. Try to, when you have dinner, put your phones away, have a conversation. It's good for brain health. So what is dementia? This is the DSM-5, and this is how mental disorders are diagnosed, and also other dementias.
Hey, Luann.
So, yeah.
I just want to tell you that we have about the previous slide.
Yeah.
He said, Clay Williamson says, to go along with the last question, when we get called to nursing homes, this is EMS, where family come to see loved ones who have cognitive issues, and they only go once or twice a year, and they call 911 because they are not the same. So that goes into like maybe denial.
And as far as the nursing homes, I used to work at a nursing home, and it's heartbreaking. There is so much denial with this disease. They want Dr. House to come in and give them a pill and make everything better. But as we go on throughout this presentation, you're going to see, and maybe you all can help educate from some of this that you're going to be learning today, and also refer them to the Alzheimer's Alliance. But the denial is huge. I've got a lady that her mom has and had an aneurysm and refuses to call it dementia, but she's cognitively impaired. And so part of that too is dementia has such a stigma to it. And I don't know if many of you all know Don Kent, but he's got Lewy body dementia. And when he was diagnosed, he's one of the few that went and educated himself on what was going on in his brain. Most people do not want to know. They're ashamed, and they want the hospital, they want EMS, they want somebody to make it right. And you can't fight this disease. It's a neurodegenerative progressive brain disease. There is no cure. And it's heartbreaking. And that maybe, you could also talk to the social worker at some of the EMS, and maybe, they could help educate the families on that. But no, I definitely hear you. That is definitely a problem. And so what is dementia? It's a general term. It's not a diagnosis. I'm going to say this again. Dementia is not a diagnosis. All right. So when people come into the office and they say, well, my husband's got dementia, I'll say, what kind dementia? Do you know? No, the doctor just said it's dementia. Well, I'm going to show you why we need to know what kind it is. So it basically is an umbrella of symptoms: being cognitively impaired, the personality changing. It's a decline in mental ability severe enough to interfere with daily activities. And now they're calling it major neurocognitive disorder. Okay, so you all may, go to a home and they may say, well, you know what, they have major neurocognitive disorder. Well, now you know that they have some form of dementia due to Alzheimer's, vascular dementia, frontal temporal, Lewy body, substance medication-induced, Parkinson's, Huntington. And I will say there's over 100 different dementias out there. So we're going to be going over the most common, what we see at the Alliance. But I'm going to also state too that major neurocognitive disorder for dementia or mild cognitive disorder impairment, these terms have not been adapted as far as universally. So not everybody's going to know what major neurocognitive disorder is, but you'll know that it's some form of dementia. And like I said, it's just an umbrella of symptoms. It's not a diagnosis. Jamie, any questions so far?
Nope.
Okay, all righty. And just interrupt me. You know, I'm in here in my office by myself. So, you know, I'd love to, any questions that people have, please feel free to chat. And also Jamie can unmute you if there's something that you would like to tell the rest of us that could help us. Like I said, it's not just me. You all have got a lot of experience going to people's homes where you've had to help somebody with dementia. So what's going on? It's a structural change. Cells are shrinking and dying. They're not producing and they're sending less chemicals. And I put in here that they can shine. And one time somebody asked me, what does shine mean? Well, it's a chemical rush. And I like to use the movie The Notebook. Any of you all who have seen The Notebook, James Garner is going to the memory care community where his wife is in. He sees her every day, and he is telling her their love story, how they met, but she doesn't know who he is, okay? And so she's listening to this story, but every now and then she recognizes him. And that's what I say they can shine. I say ping to a satellite where they're getting all bars, all 5 bars, but it doesn't last very long. And I tell caregivers to embrace that because for a short period of time, you have your loved one back, but it doesn't happen very often. But when it does, it's nice to have them. Now, dementia does not mean Alzheimer's, and it doesn't mean memory problems. You know, I mentioned a while ago that Don Kent, who has Lewy body, his symptoms were not memory loss. His symptoms were personality changing. And I'm going to go into that a little bit more in depth. So when you hear the word dementia, you may not have somebody that is having memory problems to begin with, but they're having a lot of cognition issues, okay? And I'll go into that a little more in depth. There's 4 truths about dementia. At least 2 parts of the brain are dying. It is chronic. It cannot be fixed. It is progressive. It will get worse, and it's terminal. Now, I want you to think about a caregiver and knowing that you're caring for somebody that's got a neurodegenerative brain disease with no cure. It's terminal. We do know this about dementia. It affects the left side of the brain more than the right. So what's on the left side of the brain? Speech, vocabulary, understanding content of information. As this disease progresses, okay, and I'm going to say in the moderate stage, they're missing every 4th word, okay? So, but people with high intelligence can have a lot of cognitive reserve and can kind of mask their impairment for a short period of time. This is why this is kind of a hard disease to get diagnosed, because they go into their primary care doctor for 15 minutes and the wife is like, there is something wrong. And the doctor gives them just a memory test, not a cognition test, not any other test, just a memory test. And they do just fine. There's nothing wrong. His memory's fine. Oh no, there is something wrong. Well, it's hard for a primary care doctor for 15 minutes to diagnose. And I'm going to be talking about ways to get a diagnosis. And obviously they can come to the Alzheimer's Alliance. We don't diagnose, but we refer out. Dementia affects thinking skills, okay, memory. So short-term memory can be impaired, especially with Alzheimer's disease. Recalling information that you just talked to them about 10 minutes ago, keeping track of recent events. This is really with Alzheimer's type. Preserved memories and events are still intact, but like I said, they can get a lot of the information from the past a little incorrect. Language, difficulty with word finding. May not be able to tell you that they're hungry because they can't find the right word. Judgment. This is, if the memory is poor, they're really going to have poor judgment. And that makes sense. If you can't remember things, you're going to have a difficulty with judgment. You know, flashing lights, the noise in the EMS vehicle, lights from the police, that can be a really scary thing. for them and may not understand why you're there or what are you doing there. Attention, being able to maintain, well, somebody with dementia would have a very hard time keeping their attention and listening to me. And that's just part of the disease, being able to keep your attention. Abstract thinking. Okay, so this would be, for instance, people who live in glass houses shouldn't throw stones, okay? Somebody with dementia may not understand what that means, okay? They may have understood that a long time ago, but they can't really understand that now, and they don't have the ability to have the consequences. What are consequences of what I'm doing? So I'm going to also say that safety awareness is huge with this disease, okay? They lose safety awareness. And the reason for that is about 50% of the people who are diagnosed have no awareness that they're losing skills, okay? Their caregiver and their loved ones know, but they don't know. So if you're trying to help somebody be safe and not drive anymore, well, they've been driving 50 years. You're not going to tell me I can't drive. They're going to get very, very mad. And that's because they don't have any awareness. Now, why is this a safety issue when I'm talking about driving? With Alzheimer's, if I look to the left, okay, and then I look to the right, and to the left, a car was coming, and the part of the brain, I'm going to be talking about this a little bit later, is called the hippocampus. That information never got stored into that part of my brain of a new event, new information. And I'm driving, and also visual spatial. How far is something away? I'm not going to know exactly when to stop at that red light. And I also may drive on the wrong side of the road. And I know you all have seen that before. Motor skills. And this is, as time goes on, buttoning a shirt, walking, you'll notice that in the later moderate stages to the later stages, there's a shuffle. They kind of shuffle their feet, and that affects the motor cortex. And I'll be showing you that part of the brain a little bit later. And part of the other motor skills would be chewing, swallowing. As the disease progresses, especially with Alzheimer's, they lose that ability to swallow, and they're at risk for aspiration pneumonia. And I'm going to say this because when I talk about an out-of-hospital DNR or somebody being a DNR, and that's a do not resuscitate, this is a difficult conversation to have. Social workers talk about this all the time. And I know that when I was in the hospital, long-term care, a lot of people don't want to put their loved one and have that be a DNR. In the state of Texas, as you all know, you have to have the out-of-hospital DNR in order for them to be a true DNR. They're only a DNR in the hospital, and that's if the family states that they're a DNR. But a lot of people don't understand that people can still go to the hospital with a DNR if they break a hip. This is only stating that if their heart stops, no aggressive measures are going to be done, okay? If anybody has ever seen CPR, you know, and I know a lot of you have done it, it's not a glamorous thing. That a lung can be punctured. They can end up and be intubated in the ICU. And so these are conversations, again, refer people to the Alzheimer's Alliance. And we're not saying you need to do this or that, but it's part of an education. A lot of people just need to be educated on that. So this right here, it shows different lobes of the brain. And I really like to call dementia brain failure because that's what's going on. When you look at Alzheimer's, it starts in the temporal lobe. And this is, as I mentioned earlier, where people's memory is starting to be affected. They're having a hard time understanding speech and finding the right word. They're repeating questions and phrases. And so it starts there, but then we're also going to, and I'm going to show you a PET scan of a brain, and you can see how it's starting to shrink and atrophy. But you link at the frontal lobe, and this is our Okay, I might think something, but I'm not going to say it because it's not socially acceptable, but I sure am going to think it. Well, sometimes people living with dementia lose their frontal lobe. I'll give you an example. I have a lady that her and her husband love to go out to eat, and he has what's called Binswanger's dementia, and it affects his frontal lobe. And so I'm going to say what I feel like saying, kind of like a child in a way. He's an 84-year-old man. He's been in the military. He's successful, and he's got Binswanger's dementia. And they're in a restaurant, and the little lady brings them their sandwich, and she happens to be on the large side. Now, most people would maybe notice that or not say anything, but he comes right out and says, "Man, she sure does have a big old ass on her." Now, does that stuff happen? Yes. Is that embarrassing for caregivers? Absolutely. But the thing is we have these little cards that look like business cards, and this lady uses these cards a lot, not so much now with COVID, but it just says, "Thank you for your patience. The person that I'm with has a brain disease." And do they say things? Do they use racial slurs? Okay, they know they shouldn't. Do they say inappropriate things? Yeah, this is that frontal lobe that's going on. Motor cortex, this is that walking, brushing teeth. Sensory cortex, not so much hearing loss with dementia, but if you have somebody with hearing loss and they have some form of dementia, they're really missing a lot of information. Okay, a lot. Smell and taste definitely is being affected. Jamie, you could probably chime in on this a little bit, because at Day Club, we have a lot of people with different forms of dementia, but they've lost their taste except for sweets and salty. And I mean, is it difficult keeping those sweets away from them, Jamie?
Oh, yes. They love candy, cookies. We have participants stuff cookies in their pockets, candy in their pockets. We don't have candy that often unless it goes with the theme, but we do have to check pockets, especially if somebody is diabetic. But also because if they don't have that, they crave sweets because that's one of the taste buds that are left toward the end. I tell caregivers, sprinkle Splenda on those green beans and that pot roast. It makes it more appetizing, and they do eat it better.
Yeah, they do. That is a challenge. Now, with that being said, are we able to do a lot with a piece of candy with somebody living with dementia if we want to redirect?
Yes, we sure can.
You want to give an example?
Well, if you are wanting somebody to do a non-preferred activity, you can say, well, let's get this done and then we'll go get some ice cream.
Mm-hmm.
Or if there is a negative mood, you can also use it as distraction, especially if somebody is obsessed about something in particular and talking about it over and over and over, or they're having some challenging behaviors. Offering a treat that they enjoy can really turn a mood around real quick.
Yeah. So
Also, before we go on, I want to so we had a couple of comments here.
okay.
It says, Clay Williamson says, other than a PCP, are there providers that can evaluate and test for dementia? My mother was having stroke-like symptoms and was diagnosed with brain cancer. The months after diagnosis, she knows who we are, but she will ask why we have said things and that were not spoken. We asked her PCP if she has dementia, and after 45 seconds, he says no. What would you say to
Okay.
that?
Yeah. So I'm going to be talking about that, but I would refer to a neuropsychologist. Okay, and they do a comprehensive testing. And we have a relationship with UT Tyler, and we have what's called Memory Assessment Research Center. And Dr. Barnett is the neuropsychologist. And I would definitely refer. You can either, we can send the referral to the MARC, but call the Alzheimer's Alliance, and we can help you, or we can give you a list. And I'm going to actually have a list of some of the neuropsychologists in this area that do the testing. And I tell you, it is so scientific. PCPs don't know. I don't know why they don't know a lot of this stuff, but they don't. They don't even really like dementia because there's not a cure for it. There's not any, they can give a pill that's going to help with symptoms. Okay, that would be Aricept and Namenda, the Exelon patch, but it's not like they can do a whole lot because it's terminal. And
also, Luann, I want to interject here that a PCP often does not want to make a specific diagnosis of what type of dementia because there are so many kinds of dementia and they don't want to be liable for the wrong diagnosis. That's why a specialist needs to be doing the diagnosing and treating. And a brain cancer can cause dementia because it's messing with the brain, different areas are deteriorating. I want to also say that Matt Ligaber said, I love day club, dancing and cookies. I've seen your staff redirect with cookies and candy very effectively. And we also use sugar-free cookies and candy for people who have diabetes.
Yeah. Yeah, and we love you, Matt, coming in and dancing with our people. We love that. Y'all are welcome. Once we start again, we want y'all to come back.
Yes, I've already told him. And Matt says, and pizza. Yes, they love pizza. Clay Williamson says that his mother is in Georgia, the one that has brain cancer.
Okay. So you could Google a neuropsychologist in Georgia, whatever, but you want to make sure it's a neuropsychologist, not a psychologist, but a neuropsychologist. Sometimes, or you could, go to a neurologist, but the neuropsychologist could really tell what part of the brain's being affected. So yeah, and Jamie is correct about a lot of cancers. My brother had prostate cancer, and I'm pretty sure it got to his brain, and he was starting to have a lot of cognition issues from the chemo and also from the actual cancer. So I'm sorry that you're going through that. I know that's hard. And the parietal lobe is perception, making sense of the world, arithmetic, and spelling. So somebody who's got a master's in accounting, who's a CPA, will eventually be able to not balance a checkbook anymore. So, that's, I like this slide because it really shows what's going on in the brain. The occipital lobe is huge with this disease, and we're going to really focus on that a little bit later. So the first dementia I'm going to talk about is Alzheimer's, and it's the most common, and that's what we hear the most of. Okay, 5.6 million people here in the United States. I think the number is probably higher than that. We had somebody pass away just recently of a pneumonia, and I wonder, did the death certificate say pneumonia or did it say Alzheimer's? Because the pneumonia, it was a symptom of the Alzheimer's disease. So a lot of that's not captured. But so when you look at what's going on in the brain, these are different proteins, and the protein that is in an Alzheimer's brain is it's tau and tangles, okay, and amyloid plaque, beta amyloid plaque, and it builds up in the spaces between the nerve cells, and the tangles are twisted fibers of another protein called tau that build up inside the cells. Alzheimer's is not normal aging. So if you have somebody that's 85 years old and they say, well, they're just 85 and that's normal aging. No, it's not. Now, 85 years old puts you more at risk. You have a 50% chance of getting this at age 85 or another form of dementia, but it's not part of normal aging. And Dr. Alzheimer's, that's where this Alzheimer's disease came from, actually had a 53-year-old patient back in 1909. And she was experiencing all these symptoms of Alzheimer's, and they didn't know what it was. And upon autopsy, that's how he found the amyloid plaque and tall entangles in the brain. And you can see the Alzheimer's brain on the right, how it's starting to atrophy and get smaller. People that are under the age of 65 that are diagnosed with Alzheimer's is called early onset. And early onset tends to progress a little more rapidly when you get it younger. So this I wanted to show you, the violet, the blue here, kind of just, you kind of look at that as the engine, okay? And the engine, this is the deficits that are going on. And it's like the engine is on, but you can't shift gears, okay? And that goes back to the, what we were talking about earlier on the memory, language, judgment, motor skills, perception. It's just harder to get that engine and shift gears and initiate a task. And you can also see here that the child of a 4-year-old, and then this is late Alzheimer's, and this again, safety. You can't leave people living with dementia, all dementias as they progress, you can't leave them alone. They need help. They need assistance. So the next most common form of dementia is Lewy body dementia, and it's a different kind of protein. It's the alpha-synuclein protein. And you all know who Robin Williams is. He committed suicide. This dementia, and this is what Don Kent has, they're not so much issues with memory, but Don will call it a foggy day. Today is a very dreary day outside, and he calls it a foggy day where there's times where he can't start his microwave to warm up a cup of coffee. And he still has his memory, but he's got some hallucinations, and we're going to talk a little bit about that, on how we get information into our brain, what we see, hear, smell, taste, and feel. He has taste hallucinations. Yeah, you can have that, where a steak doesn't taste like a steak, and that was actually one of his first symptoms. He has visual hallucinations where he sees a dog that was his pet 5 years ago, and it's a color visual hallucination, and he actually can go over and pet it. Now he is a retired attorney. He's very smart. He has a lot of cognitive reserve. He's able to tell himself that is a hallucination, but there will be a time as this disease progresses that he will not be able to differentiate different hallucinations, auditory hallucinations, hearing trains that are in his backyard and when he has no trains. The only hallucination he hasn't had right now is the touch feel hallucination. And that's when you feel things crawling on your body, or seeing things crawling on you. Dr. Lewy in 1912 also worked with Dr. Alzheimer's. Upon autopsy, his patient had a different kind of protein, and that's why it's called Lewy body protein, and it's alpha-synuclein buildup. Now, Lewy body and Parkinson's disease share the same protein, okay? There is a 85% chance that Don Kent might get the Parkinson's, okay? And that would be, where he has problems with shaking and rigid and at risk for falling. He doesn't have any symptoms of that now. So somebody who's got Parkinson's, who develops dementia, they have Parkinson's with Lewy body dementia. So anyway, not everybody that has Parkinson's is going to get the Lewy part of it, but they both share the same protein. So I put this in here because you all see a lot of hospitals, and I have to do this for Don Kent because he's just a real advocate for educating on this disease. So people with Lewy body dementia or a history of Parkinsonism may be especially sensitive to antipsychotics and their side effects. Haldol should never be used. And in the ER and nursing homes, that's generic, it's cheap. If somebody's having behaviors, that's the go-to drug. And some of the newer antipsychotics like Seroquel are considered safe, but still, you still have to be really, really careful with these antipsychotics. So, I mean, when you look at antipsychotics, they're for people with schizophrenia, bipolar. Doctors are using them out of indication, okay? Benefits versus risk. There is a new drug now for Lewy body hallucinations. I don't know much about it, but there is a new one that's actually indicated for that. But typically, this is what doctors go to, are the antipsychotics. And this is a medical alert card. We have these here at the Alzheimer's Alliance. You can get them from the Lewy Body Dementia Association. Don Kent carries this in the car. I think everybody with Lewy body should have one of these. And it just lets them know that it's a medical alert and that they shouldn't be given antipsychotics, especially Haldol.
Hey, Luann.
Yeah.
We have a question from Clay Williamson. Is Sundowners a form of dementia?
It is a symptom. And it's a very good question, and I'm going to explain why Sundowners happens. It's in the next couple of slides. And that happens usually in the afternoon, and it can go on all night long. And I'm going to talk in depth about it once I get to the part of brain to help you understand. Okay, vascular dementia. Earlier in my presentation, I was talking about heart health and brain health. This is not a neurodegenerative brain disease. This is actually an injury to the brain because of a stroke, okay? It could be because of brain cancer, all right? Depending on where that cancer is. But it's a problem with oxygen and blood supply to the brain. And people with diabetes and heart disease, you really need to keep that intact. Take your medication, make sure your blood pressure, if you have high blood pressure, you take your medication for that, because it does put you at risk for vascular dementia. Just because you have a stroke does not mean you're going to get vascular dementia. But this dementia is a little bit different than Lewy body and Alzheimer's, in that you'll have, Lewy body, you have good days and bad days, but with vascular dementia, they can have some really bad days where they hallucinate. And I like to use this as an example. When I worked in long-term care, I had a lady with vascular dementia who also had a urinary tract infection. And she was convinced that gnats were coming from the fire sprinkler that were in her room, the little fire alarm thing that's in there. And anyway, she saw gnats on the bed, and the LVN came in and said, no, there's no gnats on your bed. And the little lady got her cane out and started going towards the nurse and was going to hit her with it. So they called me to come in, and I said, hey, what's going on? And she said, she was angry that she was living in skilled nursing to begin with. Her daughters had put her there, so she needed to vent that she didn't like where she was living. But she said, and there's gnats. And I said, let me go get the maintenance man, and we'll see if we can get this taken care of. And so I brought the maintenance man in, I introduced her, and we went and had a cup of coffee. Now, she did have a urinary tract infection, and she was put on antibiotics, but I had to go in there every couple of times to validate. I validated an unmet need. I have gnats. You all aren't listening to me. I never told her they weren't there because she was hallucinating. She believed they were there. Now, this story is important because had the nurse continued to argue with her, I'm afraid EMS may have been called, and she would have ended up going to the ER. And then with the possibility of going to a behavioral health hospital. So we're going to be talking about how to communicate with people living with dementia. But with hers, when she got the antibiotics for a urinary tract infection, she came back to her base, and she was actually very delightful. It's just that she was at risk for urinary tract infections, and she had them frequently. And when she did, that's when the behaviors came out. Frontal temporal dementia, also known as PICS. All right, so, I mentioned Alzheimer's is the most common, then Lewy body is the second most common, but frontal temporal dementia is the most common of people under the age of 60, okay? And this is a really hard dementia. And there's 3 different types. And again, it's a different protein. It's the tau TDP43 and the FUS. So, I just put that on there so you all would know it's a different protein in the brain. And it happens to start here in the frontal lobe. So there's the progressive behavioral variant. This is where we really start seeing personality, behavior, emotions, and judgment. And then we have the progressive language decline, and that's marked by early stages in language ability, including speaking, understanding, reading, and writing, and progressive motor decline. And this looks a little bit like Parkinson's, where they have a lot of movement disorders. These people, because they can't control their frontal lobe at time, can really have some anger issues. And I'm going to show you a part of the brain that kind of will help understand what's going on. Alcohol-related dementia. Saw this a lot in the hospital. And this is caused by neurotoxicity, vitamin B1, and thiamine deficiency. This is really sad. I'm a wine drinker, but I'm going to say this about that. If you're going to drink, make sure you have good nutrition. A glass or 2 of wine is not going to hurt. When I'm talking about alcohol dementia, I'm talking about somebody that go home and drink a case of beer, okay, and has done this without good nutrition. It's going to do something to your brain. If you don't have good nutrition and you drink and drink and drink, eventually when you get older, there's a good chance it's going to do something to your brain. And this kind of shows what the brain looks like. But we have a lot of symptoms here, a lot of social control behaviors, problems with initiation, termination, a lot of decreased interest in activities, and basically just don't care. They're just losing their ability to care about anything, and they're having some memory problems and hallucinations as well. And this is chronic traumatic encephalopathy, CTE. This is from brain injuries. It doesn't, just because somebody's had a brain injury doesn't mean they're going to get this, but we see this with football players, a lot with football players. And there's been quite a few that have donated their brain, football players that have. And so some of their symptoms are frontal lobe issues, temporal lobe. Again, that's that hippocampus. So some of that Alzheimer's and frontal temporal type of patterns. Down syndrome, I put this in here because a couple of years ago, I got a referral from a neurologist, and I did not know this, that if somebody with Down syndrome has about a 50% chance of getting Alzheimer's if they reach the age of 55. So that is just, I just stuck that in there because I mentioned there's about 100 different types of dementias. Lyme disease, Chris Christopherson's my generation. I listened to his music. I found out that he was diagnosed with Alzheimer's, and come to find out, he didn't have it. He had Lyme disease. Now, had he been diagnosed a little earlier, he could have been given some antibiotics. He's doing okay. He still has brain fog, but he does not have Alzheimer's. So I put that out there because we live in East Texas, and we do have some of those black-legged ticks out there, deer ticks, but I'm a country girl. I grew up on a ranch, and I have to say that I think the fire ants are eating some of those ticks because don't have well, I haven't been out in the country, out in the woods recently, but I don't see ticks being near the problem as they were when I was growing up and picking them off dogs and picking them off myself. But yeah, that can also give you some brain fog, Lyme disease. So if you notice changes, you should get an assessment and go to the doctor. Here in Tyler, and this is what I was talking about earlier, neuropsychologist, they administer a number of tests to evaluate the functioning of each part of the brain. It's very, very scientific. And I mentioned the MARC. Dr. Barnett is the neuropsychologist. That is actually a free test here at the MARC. He uses his cream of the crop neuropsych students. They perform the test, and then he compiles the data and presents it to the person who came in for testing. We also have Dr. Martin, Dr. Schmidt, and Dr. Walker here in Tyler. And insurance will cover this. Usually, it depends on what type. If it's straight Medicare, you don't have to have a referral from a doctor. If it's a Medicare replacement plan or something like that, then you have to have a referral from your PCP. No referral for the MARC. It's just an appointment. You come in when there's a slot available, and they are testing. They're using masks, and they're doing about 2 tests a week right now.
I also want to interject that those in the eastern counties can definitely contact Beth Godsey with Texas Alzheimer's, East Texas Alzheimer's.
Absolutely. Absolutely. Okay, dementia challenges. We got a lot of those. I highlighted the ones in red that I used to see on a frequent basis, falls and injuries. So if I'm 75 and I have Alzheimer's or some other dementia, I'm 5 times at risk of falling than somebody who doesn't have dementia. And that goes to with some of the safety. I mean, I've got 90-year-olds trying to climb a ladder. No 90-year-olds should be on a ladder, especially one that's with dementia. But that's that safety awareness. I have a thought in my brain, I'm going to go do it right now, and you're not going to tell me I can't. No durable medical power of attorney. This is so important. As this disease progresses, these people living with dementia need to have somebody that can be their medical power of attorney. And also durable powers of attorney is their financial, okay? Medication management. This is huge. I took that pill. No, you didn't. Yes, I did. Or I have a caregiver whose wife had diabetes, and she also had pain. And she could not remember taking the pill. So he went to the pharmacist and got some pills, not sugar pills, because she was a diabetic, but just, placebo pills. So when she would argue with him, he would just give her another pill and it wouldn't hurt her. And he stepped into her world and it prevented an argument. Unsafe task performance, bad mouthing you to others. Yes, that happens. Swearing, cursing, sex talk, racial slur, ugly words. And I don't know if Chuck is on here or not, but when at Day Club,
he couldn't make it today.
Okay.
I'm sure he's so sad not to hear about this.
Yeah. Well, so, we had a couple ladies that just thought he was just a cutie pie. And Matt, you might be able to chime in on this too.
Matt just shared with everyone that she wanted to kiss him so bad.
Yeah. So, when that happens, you just, when I'm going to show you a technique, it's called hand under hand, and you kind of just redirect. You just can't, you got to just go with it. And, you probably remind them of somebody that was their boyfriend way back when. Who knows? But yeah, and our little ladies, they love our officers. They definitely love our officers. Making 911 calls. Yes, that happens a lot. So I have a guy in Lindale whose wife has Alzheimer's. She's in a community now. And I call them a community because I don't like to call them nursing homes, memory care, because they end up being not just the person who's living there, but the family comes in, and it's a community for the family to come visit their loved one. But so what she was doing is she was going from past to present. She was time traveling, and unfortunately, when she was a young girl at the age of 14, she was molested by a cousin. and it was not a good experience, obviously, for her. Now, with Alzheimer's, as the disease progresses, we're going to regress in age. So there were times when she thought she was 14, okay, or there were times when she thought her husband was this Leroy guy. And I first met him by phone and told him at the time she was really scared it was Leroy. And can you imagine? You know, I don't know the difference. And I think this person that molested me is in my home and I'm scared. I'm scared to death. Well, he didn't know what to do. And we tried a couple of things. But one thing that did tend to work is he would go outside and go to his truck and put a cap on and come back in. And she would say, "Oh, thank goodness you're here. Leroy was just here. Did you see him?" And she says, "No, I didn't see him." And she says, "Well, he was here." So, I mean, I tell these stories so you all can really grasp the stress and how hard it is as a caregiver. Now, she was calling 911 because thought that Leroy stole the truck, and he had a license to carry gun and was afraid that he would be pulled over for theft of an automobile. And so that was a situation where we did contact Lindale Police and let them know that when that phone calls that she does have dementia. But these things happen all the time, and I know you guys know this. 911, there's somebody in my attic. And you know, the thing is they're not calling just to be bothersome. They're truly scared. Mixing day and night, that's sundowning. I'm going to talk about that a little bit more. Refusing to stop driving, yes, that's huge. Paranoid, delusional thinking, eloping and wandering. We're definitely going to be talking about that. Threatening caregivers, sundowning, striking out at others. Now, you can see as a caregiver, not everybody's going to experience all of these, but these kind of give you an idea that there's a lot of challenges. So these are people who are productive, had enriched lives, and now they get some form of dementia and they're changing. Wandering, 6 in 10 people with dementia will wander. Wandering and getting lost is common among people with dementia, and it can happen at any stage of the disease. And this can be very dangerous. If they're not found within 12 hours, or found within 12 hours, 93% survive. If they're lost more than 24 hours, a third, and more than 72 hours, only 20% survive. And so that's what that silver alert is about. And we're going to be talking about Project Lifesaver in depth and why this program is such a good program. Who's at risk for wandering? People who go for a walk or drive and they come back later and they're not sure why they came back later. They don't remember any events. Talk about fulfilling former obligations, such as going to work. And I haven't worked in 20 years and it's time for me to go to work. No, you don't need to go to work. You're retired. No, I need to go to work. My people are waiting for me. When you start hearing things like that, or I need to go home, we need to get Project Lifesaver on these individuals. And we're hoping that we can get it in all 14 counties. Jamie is working on that really hard. Has difficulty locating familiar places like the bathroom, bedroom, or dining room. That's another sign that they're at risk for wandering. Acts nervous and anxious in crowded areas such as shopping malls and restaurants. And I like to tell my caregivers, please don't go to Buc-ee's when it's time to go to the bathroom. If you're traveling, that is too much stimulation. It's way too large, and you could lose your loved one really, really quick. Same with shopping malls. I like to recommend going to Whataburger or McDonald's to stop and go to the bathroom if you're going to take your loved one on a long trip. So the Alzheimer's Alliance of Smith County and the East Texas Alliance in Gregg County have what's called Project Lifesaver. Like I said, we're trying to get this in all 14 counties. And this is what it looks like. And it's a radio transmitter. And the alliance, both alliances have a partnership with the law enforcement and sheriff's office. I put down another option, which is the Alzheimer's Association. It's called Safe Return, but but it's not like this, okay? It's not like Project Lifesaver. It's just a medical alert. This actually is a radio transmitter, and the police officers can get out with their device and find that person living with dementia who's wandered off rather quickly. And I know that the police officers and sheriff's offices would much rather be looking at criminals than trying to find people with dementia. It's a huge cost to law enforcement. So, all right, this is a big part of the brain. This is the engine of our brain. It's called the limbic system. And the limbic system is real important as far as people living with dementia to understand what's going on. So the hippocampus plays a big role in emotion, learning, and memory, okay? And that is right here, okay? And that is that short-term memory loss. And again, with the Alzheimer's, it goes over all lobes. The amygdala is so important because this plays a role in aggression, eating, drinking, and sexual behaviors. So I usually have a video to show, but I don't have a video to show today, but it's of Kathy McCabe, and I put a rubber snake out by the front, and she thought it was real. And she's screaming all the way down the parking lot. I have it filmed. And the reason I'm telling you this is if you were to see a snake, and that particular snake scare Kathy, and you're not going to sit and say, you know, I think I should be scared. You're in survival mode. You're going to run. People living with dementia, you need to keep in mind, they're in survival mode. They are confused. They're missing every fourth word. I'm going to hit you because I don't know what you're doing to me. I am in survival mode. And that's the amygdala. That is your fight or flight. Okay. The amygdala is huge with this disease. I mentioned about the little lady who thought she had bugs in her bed, gnats, and she got her cane out and started to attack the nurse. That was her amygdala. You didn't believe what I said. Get out of here. You're making me sound like I'm crazy. She may not be able to verbalize that, but that's the emotional part is still intact. It's how you made me feel. And I've lost my frontal lobe. And just remember, dementia is going to rob you of skills before it robs you of strength. People living with dementia can be in a jerry chair and bite. Okay, so a little lady with Alzheimer's who's on hospice services in a jerry chair is starting to bite her caregivers. Now, that's her amygdala. The caregivers are approaching her too quick, trying to get it done too soon, and she doesn't know what they're doing to her. You're doing something to me, and I don't know what it is. You got into my personal space, and I don't know who you are. I don't know what you're doing. This is huge. That amygdala is huge. So y'all need to know that it's how you look and the tone of your voice when you're dealing with somebody with dementia, because that amygdala goes off. They're going to be in survival mode. And the last place we want somebody living with dementia is in jail, okay, because they struck a peace officer, all right? So we want to make sure that we don't put our people living with dementia in the wrong facility. They don't need to be in jail. But that's what's going on. It's the amygdala. I am in survival mode. Now, the hypothalamus monitors blood levels, glucose, salt, blood pressure, and hormones. And that was going to be the melatonin. All right. So somebody had asked about sundowning. And so research says that it's a deficiency of melatonin. And so there is some research that says given melatonin can help with that symptom, but it doesn't mean it's going to go away. Over 65% of people with dementia have sundowning. I have a little lady that was in the moderate stages. She's a time traveler, okay? And she gets up at 2:00 in the morning and she wants to go home. And so the husband spends just hours trying to convince her she's home, shows her all these pictures of grandchildren. We've lived here for 35 years. Well, you know what? She didn't recognize it. All right, she's been time traveling. She remembers the house she grew up in, and she wants to go home. I want to go home now. So with time, he finally stepped into her world, because that's what we got to do. They can't be in our reality. We got to be in their reality. And so he finally decided that he was going to take her home. So he told her, he said, sweetheart, get your purse and we're going to go home. And he drove around the neighborhood and came back and put his bright lights on and said, sweetheart, we're home. And she said, thank God. Now, why did that work? I don't really know, except he acknowledged and validated her wanting to go home. This is important because this caregiver was not going back to sleep. When she woke up at 2 o'clock, sundowning, okay, he was arguing with her and did not go back to bed. And I don't know why this is, but a lot of times at this stage, they can be little energizer bunnies, and they don't require a lot of sleep. So, you know, we have that day club, we have activities. We want our people living with dementia to have activities, keep them busy, because we want them to try to have a good night's sleep, because that really affects how they are the next day. But sundowning is very, very common. I hope that answered the gentleman that had the question about sundowning. The other part of the limbic system is our circadian clock, okay? Knowing what time it is, it's time to go to bed, all right? And it's time to get up. And we sleep at night. So our circadian clock with people living with dementia is broke. And that's kind of what happens with that sundowning too, is they're confused between night and day. So that's circadian clock is broke, okay? And also the thermostat. People living with dementia, most of the time, are going to be cold. And that's because the thermostat's broke. I can go to Walmart, I can go to the grocery store in the summertime and see a couple or a daughter with their mom, and I can pretty much tell just by the person, the way they're dressed, if they have dementia, because they got layers of clothes on and it's burning up outside. So their thermostat is broke with this disease. How do you identify with somebody living with dementia? Okay, so they're not going to have the judgment to understand the emergency or that their safety is at risk. Their familiar environment and routine are essential for them to function. Removing a person living with dementia from their home can be very disorienting. And again, we're going to talk about that positive approach to care. How do you approach somebody that you need to get them to leave the house or, you know, go to the ER because they're going to be very disoriented and they're not going to want to leave their house. They may have difficulty with their hearing or vision. It's possible that they are not making sense of the situation. They may think it's 1987. They may think that you are their son or daughter. And at that point in time, if you can get them safe, it's okay. Okay. It's okay if they think that, because your goal is to get them to where they need to be. And again, they're going to come in and out of cognition on that. They may be disheveled. If they're living alone, you may notice their house might be real messy. They may have food laying around, stacks of mail unopened, expired food, notes all over the wall and phone, reminders around the house, confusion, difficulty understanding the conversation. They may mistake you as a family member. So that might work to your favor at times. And you just want to always have a smile on your face. How do we get information into our brain? What we hear, what we see, what we feel, touch, smell, and taste. Now, I had mentioned about Don's Lewy body dementia. It affects all senses. Dementias affect all senses, okay? It's affected his smell, his taste. He has taste hallucinations. He smells cigarettes when nobody is smoking cigarettes, okay? He has had visual hallucinations and auditory, and you can also have touch and feel hallucinations. So Like I said, with dementias, all the senses are affected. Misinformation, misunderstood information, overreaction to information, underreaction to information, get stuck on a sensation, can't stand a sensation. Variable abilities, can't adjust or adapt to a sensation. Jamie, could you just chime in for a minute? Because you've been working with people in day club, and why the senses are affected so much.
Well, I believe the senses are affected so much because those are the parts of the brain that are being affected by the disease.
Mm-hmm.
And we make sure at Day Club to engage with our activities every 5 senses, because that helps stimulate those areas of the brain, if that makes sense.
Yeah. So some of the sensations, when you're introducing it to somebody in day club, they may not like that sensation where somebody else might. And so, I mean, it's interesting as this disease progresses, how all the senses are affected. Memory, immediate recall, attention to selected info, recent events, preserved abilities or long ago memories, confabulation, emotional memories, and motor memories. Impulse can become liable and extreme. Think it, say it, want it, do it, see it, use it. Preserved abilities is, as we all do as human beings, we have a desire to be respected, and people living with dementia have a desire to be respected, a desire to be in control, and can actually regret of an action that they've done. But sometimes not, because we've lost that frontal lobe. Being able to understand someone else's point of view sometimes is gone with dementias. Understanding.
Or Luann, they forget that they even did the behavior.
Yes, which can be very hurtful for the caregiver, that they did a hurtful behavior to them, not on purpose. And now they're not even going to get I'm sorry because they don't remember what they did. So there's a lot of education with this disease. And as you can see, understanding language, this is a great slide because you can see that, I mentioned earlier, they're losing every 4th word. Understanding, can't interpret words, missing some words, gets off target. Preserved abilities, can get a facial expression. This is so important. People are paying more attention about how you look. So some of you guys that look mean and serious, when you're around somebody with dementia, you need to put a smile on, okay? Because you're going to get a lot more with a smile than not. Your tone of voice is really going to affect somebody living with dementia. Your tone, how it sounds. They can get some nonverbals, and they also learn how to cover, and those are preserved abilities. Language, can't find the right words, word salad, single phrases, sounds, vocalizing, can't make needs met. What is preserved is singing, and we do a lot of singing and dancing at Day Club. You might be able to get a lot if you all like to sing. I have been able to get a young lady in an ambulance by singing Sugar Pie Honey Bun, You Know That I Love You. And this little lady, the only thing that she could really say is I love you, and I would tell her I love her back. But we sang all the way to the ER in the ambulance, and I was really afraid we were going to have to try to get an EDW because I thought she was going to go fighting, but she didn't. Swearing, sex words, forbidden words, those are preserved. People wonder why people with dementia cuss. Well, that's because they learned those words a long time ago. They're in a different part of the brain. And when they're looking for the right word, maybe a cuss word will come out every now and then. And it does, it happens. Auditory data. I mentioned this earlier, and I can't stress this enough. What we do often too wrong is we talk too much. The person with dementia is focused on how we look visually, and they are not processing the content. And this kind of shows what's going on in the brain right here. I think these slides are important to understand that automatic speech. Somebody may have that rhythm that's on the right side of their brain. where they know what a conversation sounds like, but they're not getting the right words, but they have that rhythm where they are talking and they make no sense at all, but they have that rhythm. That's me on a unicycle. And the reason why I put that on there is Jamie and Kathy, if I ever have dementia, I learned how to ride this when I was 8 years old. And I'm not going to tell you how old I am, but I'm too old to be doing this. I can tell you that much. But I want you to bring that to my memory care, because my motor cortex will be intact for a while, and I'll be able, that's a muscle, that is something that, as Dr. Schmidt told me, it's in my basal ganglia. I've given that to a lot of people to try to learn how, and because I learned at a young age, I can still do it. Sensory changes, awareness of body position. You'll notice that people living with dementia will kind of be, as a disease progresses, they have a hard time sitting up. Ability to locate and express pain. This is huge, that they can be in pain and not be able to tell you, and you can have a behavior from that. You can ask them if they're in pain, and if they don't understand what you're saying, what do children do when they don't want to do something they don't understand? They always say no. We hear no all the time in the world of dementia. There's 4 areas that can be very sensitive, and that's the mouth, the lips, the hands, feet, and the genital areas. Sometimes you'll see people, using their hands, or they're tapping their feet. Those areas seem to be real sensitive. Rubbing their genitals, especially if they can't express that they have to go to the bathroom, that may be their way of telling you. Need for sensation can become extreme. Self-care, this is where we start seeing problems with taking a shower. And, I mentioned about the autonomic nervous system. Their thermostat is broke. It's very hard sometimes because people don't want to get in the shower, or they don't like the feeling of the water hitting them, and they're cold. And that's part of that thermostat. Preserved ability, emotions and actions, doing the part, cued activity. You can help a person by saying, hey, watch me, let's do that. I mentioned driving here in Texas. You can have the medical doctor send, and this is the email address, to have a driver's test done. Just because they get something in the mail doesn't mean, if I have dementia and someone's trying to take it away and I get something like that in the mail, I'm going to have enough smarts to me to throw that away, because nobody's going to take away my driving. But that is one way we can help, is they can go take a driving test. Dr. Barry Rath, he charges $300. He does a driving simulator reaction test. But this can also give caregivers a false sense of security, especially if they have Alzheimer's. I had a patient go in for this and did not remember taking the test and asked for his keys. And the wife said, don't you remember? You agreed not to drive yesterday. And of course, he did not remember that event. And that is typical Alzheimer's. Hearing is not affected that much, but as I mentioned earlier, if they're hard of hearing and they have some form of dementia, they're missing every 4th word, they are really not understanding what you're trying to do. Vision, and I mentioned this earlier, we're going to be talking about the occipital lobe. You can see big changes. And so as we age, at 75, I don't know if you all can see me or not, but my peripheral vision, this is normal aging, I'm going to lose a lot of my peripheral vision. Somebody living with dementia in the moderate stages are going to be more like this, binocular. And can you imagine seeing the world like this and not having any peripheral vision? I still may have my 20/20, might need my glasses to read, but I'm losing, and this is with all dementias, I am losing my peripheral vision. Most powerful sensory input is visual data, okay? People pay more attention to what they see than what they hear. Big with this disease. Also, personality traits. Of course, you don't know if somebody's an introvert or an extrovert, but my introverts out there, if I were to come up to you and get in your space, you probably wouldn't like it. I'm an extrovert, if somebody wanted to hug me, I'd give them a hug. Well, with COVID, you need to have your mask on, I guess, social distance, maybe do one of these things, but of course, you don't know what their personality traits when you're a first responder, but you might want to just assume that they're an introvert. And this is really, really important because you don't want to get into someone's personal, private space, okay, until they see you coming and you get a visual that it's okay to get into their personal space. If you don't, remember that amygdala, I am in survival mode. You just got into my personal space and I don't know who you are and I don't know what you're getting ready to do to me. No touching until you've done a visual verbal connection. You don't want to do to someone, you want to do with. If they think you're going to do something to them, they are going to be upset. Dementia robs skill before it robs strength. And we're going to show you. This is TIPA Snow. This is a hand under hand. All right. So it's a handshake. But what you're going to do is the person living with, you're going to turn your hand down and the person living with dementia's hand is going to be on the top. Okay. And I'm going to show this to you in a video. It allows you to feel in control, the person to feel in control. It connects you to the person. And I mentioned earlier, it allows you to do with a person rather than to. And, it says use the person's dominant side. We don't really know what the person's dominant side is. You can do this with the left hand, but most people shake. So it's a handshake, and then you turn your hand down, and the person living with dementia is on.
This is what I'd like for you to do. I want you to do this, okay? All right? So he's in the moderate stages of dementia, and he's got tunnel vision. Now, what I don't want to do, I don't want to come up to Chuck on his side because I could startle him. I want to make sure, and I don't know if he's an extrovert, an introvert. I know nothing about Chuck. I have nothing to go on, okay? But I need to work with Chuck. So I want to make sure before I get into his personal space that he sees me and I get down here to his eye level. I go, hey, Chuck. Now, if I don't do this and I come up to him, okay, and I want to do something with him, what's he looking at right now? What are those?
Boobies?
Correct, those are. And so, any women here ever been touched inappropriate with somebody living with dementia? Well, if you haven't, it could happen, okay? I've done some training with EMS, and the EMS ladies say, oh, all the time it happens. And it's because of this frontal lobe. I see something, I want it, you just put it in front of my face. Don't arrest me because I touched you. You're the one that put them in my face, okay? So what I want to do is I don't want to approach Chuck that way. I want to say, hey, Chuck, it's Luann. Hey. And I'm going to stick my hand out, and I'm going to wait for him to stick his hand out, okay? Now, we learned this at a very young age, how to shake a hand. And I'm going to get down here to his eye level, okay? I'm going to say, hey, Chuck, listen, I really need your help. Can you come out and help me?
Absolutely.
Okay. Now, I'm going to keep his hand, all right? So this is hand under hand. It's a handshake, but the person living with dementia, their hand is on top, okay? And I'm also going to say that if his amygdala, he's not quite sure, we know there's research that says the palm is very comforting. And I might want to stay here in this position until he feels more comfortable, but he's already told me it's okay. So I'm going to help him stand up, okay? And you can see I'm still hanging on to him. And I can put the palm on his shoulder, and I can walk with him and take him out of the house. Okay?
Okey-dokey.
Now, the other thing that I'm going to show you with hand under hand, and I'm going to ask Chuck to sit back down, and this would be for caregivers out there. Chuck is in the later stages, and he needs a bath. And so what I'm going to do is I'm going to warm up some towels in the dryer, and I'm going to disrobe him, and I'm going to assist him with bathing with the hand under hand, okay? So I can have a washcloth, And it makes him feel like I'm doing something with him and not something to him, okay? All right, and as I keep doing this, that emotional memory, because he's been doing this for a while, he may take over and start bathing himself. And I could go like, hey, Chuck. And he, would wash his private parts. So the other thing I can do with the hand under hand is if he needs assistance with feeding, I don't want to feed him like this. Okay, he's a grown man. I'd want to get on his side and pick up the utensil and feed him like this, okay? And I might be able to transition to where he starts to feed himself. But it's that initiation. Sometimes with this disease, they're not going to recognize the fork, and so we have to kind of get it going. And that hand under hand, that positive approach to care is so important when you're approaching somebody living with dementia. So let's give Chuck a big round of applause. Thank you very much.
Another thing that's going to help, 5 ways to say you're sorry. Saying I'm sorry to somebody with dementia helps them understand the best they can that you're trying to help. And when you think about, if you're upset with somebody and they come up and say, hey, listen, I'm really sorry I hurt your feelings, it makes you feel better. It's like, well, they understand. So these are some things that you can use with people living with dementia. I'm sorry, I was just trying to help. I'm sorry I made you feel angry. I'm sorry I made you upset. You need to name that emotion. I'm sorry I made you feel like a child, like you're stupid. I really need your help. Can you come with me? I'm sorry this happened, and I know this is hard for both of us. So that just kind of gives you some ideas of how to say I'm sorry. So I gave you all a little test, and we're gonna fill it out together, okay? So you don't turn this in. This is just a test. Did you learn what I wanted you to learn today? As a first responder, it's important to respond, not react. Point out what the person with dementia is doing wrong, or take over. Which one? Okay, A is correct. As a first responder, if something isn't working well, who needs to change? The first responder or the person living with dementia?
A, lots of A's. There's first responder.
Absolutely. If it's not normal aging, it's always dementia. True or false?
Everybody's saying B, false.
That is correct. Human beings taking data 5 ways. The most powerful sensory input is visual, auditory, kinetic data.
Everybody's answering A, visual.
Awesome. People with dementia pay more attention to what they see than what they hear. True or false?
Everybody's answering true.
That is true. All forms of dementia, I got it, attack. Oh, it's supposed to be attack, not attach. Sorry about that misspelling. Attack the brain asymmetrically. What side is usually attacked first and more severe? The left or the right?
Everybody is saying, and there's some question about this, is it B?
It's the left side. So the left side is speech, language, and understanding content of information. The right side is our rhythm, our singing, our chit chat. So it affects the left side more than the right. Good. When approaching someone affected by dementia, it's okay to touch the person before you make a visual and verbal connection. True or false?
Everybody says false.
Correct. Please choose the correct statement. It's more effective to do to a person than with, or it's more effective to do with than to a person.
Everybody's saying B.
Correct. People find pressure in the palm of their hand comforting. True or false?
All answers say A, true.
Good. A person infected with dementia retains safety awareness.
B.
Correct. The amygdala and the hippocampus are 2 parts of the limbic system of the brain. Both of these parts have primary functions that relate to memories and reactions to emotional aspects. True or false?
A. Everybody's saying A.
Good. Working memory peaks at around age 45, 75, 25.
Unfortunately, answer is C.
Yeah, I know. Choose all that apply to normal aging. Can't recall a word, but can describe it. process information more slowly, may pause when word finding. Words won't come even with verbal, visual, or touch cues. So let's choose all that apply.
The normal aging.
Normal.
Mm-hmm. They're really thinking on this one. Okay, we got a split here. Some people say A, B, and C only, and some are saying A, B, C, and D.
Okay, it's A, B, and C. D would be not normal aging because words won't come even with verbal, visual, or touch cues.
Mm.
Okay, so I may pause when I'm trying to find a word. You probably saw me do that today. Process information a little slowly. That happens. Can't recall a word, but can describe it. Yeah, that's all part of normal aging. A, B, and C.
I've got a question here real quick. I think this is a good question. If you are left-handed, is the right side of your brain affected first by dementia?
That's a good question, but the research says the left brain is affected more severely than the right.
No matter what.
No matter what, but that's a good question.
Okay.
Choose all to apply to not normal aging. Unable to get started on a task, will get stuck in a moment of time, unable to successfully place a person, and confused between past and present. All that apply.
Hold on a second. Okay, let's see what everybody is saying. Oh, it's kind of a mixed bag here of answers. So some say B, C, D, some say all of them. Maybe you should tell us the answer.
It's all of them. It's all of them. Yeah. So I think, oops, no, I still have another one. Dementia will rob you of skill before it robs you of strength. True or false?
Pretty much is A. Everybody says A.
That is very true. And keep that in mind. Even that little lady in a jury chair can bite if she thinks you're doing something to her and she doesn't understand.
Mm-hmm.
And so offer empathy, go with the flow. We don't do reality orientation, okay? We try to step into their world. I gave you a couple examples of when I stepped into the person living with dementia's world, or their caregivers did. And I say no telling lies, but you know, if we are stepping into their world, are we telling a lie? No, we're stepping into their reality. So anyway, it looks like I have 1 minute left. And so, Jamie, I'm going to let you take it from here. And I want to thank everybody for listening to me for the last 2 hours. I wish I was in person. I'd much rather do this in person, but I appreciate the ones that have logged in, and thank you very much.
Thank you, Luann. All right. We are privileged to have with us today as our next speaker, Jean Saunders, who is the CEO and founder of Project Lifesaver International. And I'm very excited. I've never heard Jean speak. I've talked to him on the phone quite a bit, but I'm looking forward to this. Let me read his introduction to you. Jarvis E. Jean Saunders Jr. founded the Project Lifesaver Program on October 1998 while serving with the Chesapeake, Virginia Police Department as a captain commanding special operations in SWAT and chief of SAR, Chesapeake Sheriff's Office. When it became apparent to him there was a major void that needed filled. Project Lifesaver International is a 501c3 community-based public safety nonprofit organization that provides law enforcement, fire rescue, and other first responders with a comprehensive education, training, and technology-based program for individuals with cognitive disorders who are prone to life-threatening behavior of wandering, including those with Alzheimer's disease, autism, Down syndrome. Project Lifesaver was the first organization to apply locating technology for the search and rescue of individuals with cognitive disorders and have remained the leader, the gold standard in this field for nearly 17 years. Jean has been a leader in the development of material and training programs to provide the necessary education for doctors, caregivers, school administrators, first responders, search personnel, and of course, the family of loved ones at risk. In fact, Jean is a subject matter and expert advisor on the wondering issue for leaders engaged on Alzheimer's disease, which is LEAD, L-E-A-D, National Centers for Missing and Exploited Children, the International Association of Chiefs of Police, the Alzheimer's Foundation of America, National Alzheimer's Project Act, and the National Council of Certified Dementia Practitioners. Project Lifesaver program is now in 50 states, the District of Columbia, and 7 provinces throughout Canada, with over 1,527 member organizations. The success of the program can also be measured by the lives of the at-risk individuals and their families the program has touched, with over 3,500 rescues. Today's learning objective with Chief Saunders is awareness of Project Lifesaver, how it works, and who does the program and the benefits to our communities.
Good morning. Good morning, everyone. Thank you for having me. It's a privilege. As you can probably tell, I am on a borrowed laptop because right now I'm in the midst of training Osceola County, Florida in airborne search techniques with Project Lifesaver. So going back to the introduction, what is Project Lifesaver? Well, I think to really answer that question, I need to give you some history. As mentioned before, I was in charge of SWAT and search and rescue. Well, in the 90s, especially in the mid-90s, we started to see an uptick in our area, which was Chesapeake, Virginia, in the Tidewater area, of missing Alzheimer's patients. Well, at that time, there was very little understood about missing Alzheimer's patients or how to search for them. So how did we search? We searched just like we would for what might be regarded at the time as a normal person. We didn't know at the time, and nobody could tell us that doesn't work. So our searches were, as you can imagine, not very successful. Well, this continued. Well, at one point, our sheriff, and we had transferred the search and rescue ability and function over to the sheriff's office with the caveat that I would volunteer and go with it, which I did, which made my wife very happy because I just added another job with no compensation. However, at one point, we were still having the same problem. The sheriff sent me a brochure. He had been to the National Sheriff's Conference in some location and picked up a brochure on wildlife tracking. And he sent it to me through the mail with little afterthought as to what it might mean, except this looks good, I'll send it to Jean. As I sat and read it, I felt like, you know, we can do this with wildlife, and we've been doing it for some time. Why can't we adapt this technology to at-risk people, provide them with a transmitter, and should they go missing, be able to track that radio signal? If we can do it with wildlife, I don't see why we can't do it with those people. So I contacted the manufacturer of the wildlife tracking equipment. We worked out some things and we got established a wrist transmitter that had a radio transmitter in the bracelet itself. Well, that all took place, and then on April 9th, 1999, we established Project Lifesaver in Chesapeake, Virginia. Well, initially, my thought process was only for Chesapeake, Virginia. It was not for any other area, although I should have thought, because we have 4 major cities that are contiguous to Chesapeake, Virginia: Norfolk, Virginia Beach, Portsmouth, and Suffolk. Not having that in mind, the sheriff called for a press conference. So immediately following that press conference and a short demo of what we were doing, the calls started coming in. Ironically, the first calls did not come in from Chesapeake. They came in from the neighboring cities. Well, the sheriff in his wisdom said, well, if we're going to do it, we'll do it for everyone that calls in. So that's how it started out for those cities and in Chesapeake. Well, as it progressed, the neighboring cities were seeing that we were responding into their area to do these searches. So then they decided they were going to adopt the program for themselves. Well, that added another wrinkle to what we were doing. Now we had to come up with a certified training process. You guys in law enforcement, you know what I'm talking about. So I had to develop a training syllabus, go to the state, get it approved so that now we could train law enforcement agencies and they would get credit for it and certification. We were able to do that, but again, another wrinkle got added. Other jurisdictions in the state of Virginia and other states, through our contacts with the national sheriffs and other agencies, discovered what we were doing. They seemed to like it. And the reason they were discovering, I need to back up, is now we were making rescues. How were we making these rescues? Well, as all of you that have been on a search and we were not tracking a radio signal, you know how time consuming and how frustrating it can be. One such search that we did prior to Project Lifesaver for a 79-year-old Alzheimer's patient took us 2 weeks. The most discouraging part of that search was when we found the gentleman, he was deceased. He was 1/4 of a mile away from where he was last seen. And we assumed or deduced that it looked like he was trying to go en route to his last workplace. Very discouraging. So now we are making the same type recoveries and rescues within minutes. Our average time at that point was 15 to 20 minutes. Right now, average rescue time is 30 minutes or less. So the word started getting out about the rescues that were being made. So other agencies kept inquiring and calling and wanting the program. So now we're not only doing the program for now Chesapeake because the other cities had adopted it, but we are traveling. The very first place I traveled to was in Kansas. Then it got to the point that every bit of leave time, because I was still full-time with the police department, every bit of leave time I had was being burned going out and training agencies. This went on for about 2 years. At that point, it finally dawned on me, slow thinking as I was, I need to make a choice. I'm at a period now where I can retire and go full-time with Project Lifesaver. Otherwise, I'm not going to be able to continue this. So I chose to retire and put full-time effort into Project Lifesaver. Now, since that time, and I'm going to update some of the numbers that were given to you earlier, we have now a membership of 1,607 agencies. We are in all 50 states, 9 provinces in Canada, and we're getting ready to stand up in Western Australia. We are rapidly working towards international frequencies so that a lot of countries that have been talking to us, such as the UK and others that want the program, and we didn't have the frequency ranges that we could use, we can hopefully shortly we'll be able to do that and stand the program up in those countries. The program, as you heard, is a 501c3. Now, how did that happen? Well, when we first started, we were part of the sheriff's office. Shortly into it, our lawyers, and you know how lawyers are, got involved and says, I don't think you can sustain this as a part of the sheriff's office. You need to separate it. So we went and looked at, should we go just as a for-profit corporation, or do we want to look at a 501c3 nonprofit? We chose the 501c3 nonprofit because I believe this should be a service, not a profit-making venture. Therefore, we filed and we were granted a 501c3 status. So There we are. That's Project Lifesaver. We have 2 offices. Our headquarters is in Port St. Lucie, Florida. Our operations and RF division is in Chesapeake, Virginia. We opened our office in Florida just going a little over 10 years ago. So that gives you a little history of Project Lifesaver. Now, how does Project Lifesaver work? Well, the first thing that happens is an agency that wants to become, a Project Lifesaver member will contact us. We will then coordinate with them setting up the acquisition of the equipment, for which there is a charge for. Unfortunately, our distributors, or our manufacturers rather, who make our equipment do not do it for free. So we have to pay for the equipment. Now, the question comes up sometimes, well, can I just buy this equipment? Well, the answer is no. We do have an exclusivity, and that is because we don't need a helter-skelter search approach out here with 200 or 300 or 400 people anytime they want to do this. We will then set up a training date, working with you and your agency. Now, we normally train around 7 operators. We'll send 1 instructor in. The agency is responsible for the acquisition of the equipment and the expenses of the instructor. We will send the closest instructor we have to help cut down on the cost. The instructor will then spend about 2.5 days with the agency, training them not only in the use of the equipment, but as you were, privy to prior to me, we will give you some insight as to the disorders that you're going to be dealing with, such as Alzheimer's. How do you interact with an Alzheimer's patient? An autistic child, how do you interact with an autistic child? Because I tell agencies, and I tell any of you that do searching, finding them is only half of what you have to do. Once you find them, if they are ambulatory, you now have got to get them home. And they are not always the most cooperative. So that is part of the training we do. Then we're going to train you, how do you use the equipment? What do you do with the equipment? If the equipment is malfunctions for some reason, how do you know it and how do you troubleshoot it? We will then take you out and put you through scenarios after we have gone over all the search patterns we've developed over the years to locate the radio frequency signal. And I'll go into that a little bit more in a few minutes. You locate the signal, you are then going to track that signal. Now, this is not any new high-speed, low-drag technology, and some of you know what I mean when I say that. This is technology that has been around since World War II. In fact, the Allies used to track down spies by picking up and radio direction finding their radio signal. Well, that's exactly what you're doing with this. You are direction finding that radio signal, going into it, moving in that direction, getting closer and closer. So now that you have picked up that radio signal and you've got them, the radio signal, digressing, comes from the bracelet. Each person has their own individual frequency number. Now, for you guys that are technical, you'll understand what I'm saying. I'm going to try to simplify it so that everybody understands. Project Lifesaver operates in the 216 megahertz band. Now, that means every frequency that's allocated is within that band. Now, where we differentiate people is in the kilohertz, such as, let's say that you have a person, you have placed a transmitter with them. They are in they have 216, 190. That means to locate that radio tracking bracelet, you're going to dial in 216, 190. That separates them from everyone else that may be in your program. All of these radio signals are digital. They are not analog. What does that mean? Well, analog is old radio technology, and those frequencies had a tendency to drift. For instance, if I just, as I told you, gave you a 216-190, and I wanted to search for that person, and I tuned in 190 in an analog system, that frequency may have drifted to 192, 193, or down to 188, 187, which means now, if you don't get that frequency right away, you've got to start searching for it. In the digital era, they are much more accurate. You tune in 190, you're going to get 190. All right, we're at that point. I hope everybody understands. If you have any questions, I'll be glad to cover them. You're going to track to the person. You're going to locate them. Hopefully, you're going to find them. As of right now, our agency members have had documented over 3,700 rescues without a failure. And we're still operating within that 30-minute recovery time rate. So I'm very proud of the agencies that have done that and that are doing that. Now, what is it that we are talking about? All right, I don't have any fancy videos, but I do have some things I can show you. That is the transmitter. As you can see it, and of course, I had it upside down. There it is. It's housed in that little plastic case. That case is water resistant. People ask me, well, is it waterproof? It is water resistant, highly water resistant. I answered, no, there is no such thing as waterproof. You put something in water long enough, it's going to find its way in. Normal living conditions, this will resist any water penetration. We even have some autistic children that wear them in pools, and if they're assembled properly, they will last a long time. We even have them in colors. This is very useful when you're dealing with a person with some vanity and children. They like colors, and we have different color bands to put them on. Now, as I said earlier, there's a transmitter inside. That transmitter is transmitting on a 216 frequency. It is sending a signal 24 hours a day, 7 days a week, and it transmitted every 1 1/4 second. Now, how does that, sound when you're looking for it? All right, that's a receiver. That's a handheld, all one hand receiver. Okay. Now, if I am tracking and I've got it tuned in to this particular transmitter, which is a 216-757, once I contact or make contact with that signal, this is what I'm going to hear. Now, part of our training is we train you on how to read that signal and move in closer to this transmitter to the point that you have the person in your possession and able to transport them. So that is the two components. Now, we also have some other things such as an omnidirectional antenna that fits to the top of your car.
Hey, Gene.
Yeah.
We have a question. Sorry to interrupt you.
You're right. That is a chirp.
It is a chirp, not a beep. I think we answered the first part of Melissa Drigger's question using the digital searching equipment, the antenna, but it is real-time tracking.
Yes.
And you said it is a bracelet. How do you keep your loved one to wearing it?
I've asked that question a lot. Most of them you don't have a problem with, but there's always a percentage that want to play with it or they want to cut it off. The very first thing you need to understand is this thing stays on them anywhere from 30 to 60 days, depending on the model that you want to use. The battery has to be changed within one of those time spans. Now, keeping it on, we tell you and we tell the loved one, don't allow them to get around sharp objects or scissors. If that doesn't work and they do get one off, we call that a training exercise. I have responded where they've gotten them off, found them in desk drawers, in garbage cans, empty dumpsters, and replaced it. One of the tricks that we learned a long time ago was instead of the wrist, put it on the ankle. That way it is not as obtrusive, and it's not noticeable, and they don't tend to play with it as much. Funny about that, the ones I find that I have to put it on the ankle the most often, you'll never guess, it's men. Men seem to be more vain about wearing one of these on their wrist than women do. So that's the kind of, also there's other things. You can use your ingenuity. We had an Alzheimer's patient, was a lady, carried a doll baby everywhere she went. Never let go of that doll baby. So what we did was put the transmitter in the head of the doll baby, because we knew if she was gone, the doll baby would be with her. So we could track the transmitter while it was in the doll baby. But there's other things, and you know, we have some very ingenious things that these agencies have come up with. One of the things we do, now that I'm saying that, is we have an annual conference. Every year we have it in Orlando, where all agency members come together. We have speakers that cover the latest in Alzheimer's, autism, the different disorders, the latest in the tracking technology, the latest in our equipment upgrades. But the best thing we found that comes out of these conferences is the interaction between the agencies. When they come up with a problem and they solve it, they come and they share it with the other agencies. And it seems to work very well. As most people in law enforcement know, the best ideas that you can come up with, you either share them or steal them and put them into practice. So this is a good opportunity for people to do that.
We have lots of ideas for Melissa or anybody else who wants them.
I am sure, and they can, you know, very definitely be shared. As I said, these particular transmitters, we program them. They're take-aparts, and I'll show you. The back screws off. One reason we do this is, yeah, we'll have some that damage the case. Well, rather than having to worry about the case being damaged and having to replace the whole transmitter, all we have to do is replace the case. That is the transmitter right there. This is the battery that powers it. Depending on what you want, it can be a 30-day transmitting or 60-day transmitting. And that is your choice. If one's damaged, the case is damaged, you don't have to change it out and change the frequency. You just change the case. It makes it a lot simpler for us and a lot easier and more efficient for the agencies that are doing the program. Now, some of the other things that we do, as I alluded to when I first started, we do have airborne tracking programs. We train your helicopter unit and your searchers on how to do it from a helicopter. The only pre-requirement is that for us to train your searchers, they must already be ground electronic search specialist qualified. Because then once that has reached a point, then we can take it up. The frequency band is the same nationwide with a couple of exceptions. I'm glad you asked that question. The FCC many years ago granted us 216. Why did they put us in 216? Well, we first started in 215. As we progressed and we went into a couple of years, we found that in some agencies, we were having a lot of problems in the 215 area. A lot of static and white noise, to the point that it was completely washing out the signal. Well, we learned through some research that 215 was sold to HD TV. So where were we having the problems? Wherever there was an HD TV channel that had come into being, it would totally wash out that frequency. That in mind, we go to the FCC. Hey, we're having this problem. What are we going to do? We've got agencies that can't even do searches. Well, in their infinite wisdom, they kind of sloshed around in their frequencies and they came back and said, okay, we're going to put you in 216. Now, a little history on 216 because you're liable to hear this. Yeah, I'm going to address drones in just a minute. 216 at one point in the Midwest was a wildlife tracking frequency. But what the FCC said at that time, now you got to remember this was back 2007, 2008. They said, we're going to put you in 216 because it's not used as much. And as these licenses for the 216 wildlife tracking expire, we're not going to renew them. So within a couple of years, you're going to be completely in the 216 by yourself. Now, the question may be, well, how would you differentiate between tracking a wildlife or tracking a person? Well, we encoded our transmitters. So if you're listening to 216.190, every so many chirps you would get, if it was our transmitter, you'd get a Morse code letter, which would tell you, yeah, that's my Project Lifesaver transmitter, that's not a wildlife transmitter. So you could differentiate between them. Now, in some areas in the country, not many, 218 is where we're at. And that came from the FCC. And I need to show you when I'm talking that this particular receiver is capable, as you can see right here, of tracking anything from 215 to 218 just by resetting the megahertz tuner. 218 is used when we have some interference, unidentified interference in the 216 band. For instance, Los Angeles County uses 218, some areas in Los Angeles. At this point, the FCC nor we have been able to identify why the interference is there. Accomack County, Virginia is the same. There is something out there. We have not been able to identify what it is, but they're now in 218 and operating fine. So if they call in outside assistance, all they have to do is tune those receivers to 218. And they're in the ball game. They can track as well as Accomack County. Now, one of the reasons we do this is we require the agencies to acknowledge that they will support any other Project Lifesaver member that is close to them. For instance, in the Tidewater area, we had Norfolk, Chesapeake, Portsmouth, and a couple of others, Virginia Beach. Many times, if we had one of our clients go into Norfolk for some reason and wander, and we would get the call to respond, we would notify Norfolk, their Project Lifesaver team, and say, okay, we're coming into your area. This is who we're looking for, and this is their frequency, and this is where they were last seen. Many times before we could ever get there, Norfolk would call us back and say, we have them, we'll meet you at such and such location. And the same with the beach and other areas. So these are, very useful in being able to do this. Yep, guy from Virginia Beach. Yeah, they used to, they wear a lot of them. In fact, Virginia Beach has almost 500 clients.
We have a question, Gene. All the hunters using tracking dog technology around here, does this cause interference?
No, they're on a completely different frequency. So there's no interference between them. And I know you've seen some similar equipment, but being individual in our own megahertz band, we don't have any interference with the hunters. Mm-hmm. All right. Any other questions? All right, I'll move on. I'm glad that Virginia Beach Medic said what he did. One of the things that we did is you will see on the top, you will see where it says Project Lifesaver. If I can get it turned up right side up. When we first started, we didn't put markings on the transmitter cases. Well, inevitably, if somebody was transported to the hospital for some reason, most of you know what the first thing that happens is all jewelry and anything that's on them is removed. So it would get cut off. Well, because they didn't know what it was, it went right into the hazardous waste bin. And from there, it usually went to the incinerator. So we learned a lesson very quickly. Identify the transmitter. And one of the identifications you can do that we offer agencies is a sticker on the top that will give a phone number that they can call. And it'll say something like, if lost or found, call this number. Have Project Lifesaver. So if a hospital gets it, they get the number, they can call you and notify you, I have this transmitter. If you want to pick it up, you can pick it up. Afterwards, when they are released, you can go back and reinstall it. So I think I've pretty much covered a lot of how it works, where it came from. We are working on the drone technology. We do have a drone. Most of you may know that. The drone is the Lockheed Martin Indigo, and it is configured to track our bracelets. However, the downside to the Lockheed Martin Indigo is it is $45,000, which is an exorbitant price. There are about 15 or 20 of them out right now with agencies. So we heard you. We heard the agency members saying, we really want this technology. However, we don't have $45,000. Well, we are now working with one of our suppliers to produce a drone antenna that will fit on a DJI Mavic Enterprise drone. That drone is in the $3,300 range. The Mavic Enterprise was specifically manufactured for public safety use. It comes with FLIR and video and still picture capabilities built in, and it has a load port on the top where you can attach the antenna. Once it goes out, then it will send a signal back to the operator and tell you what the signal strength is and where you are in proximity to the transmitter. Now, how does this aid you? Well, the same as in a helicopter. On the ground, we bench test these receivers and we get about 1 mile. Now, in actual use, you're talking about anywhere from 3/4 of a mile to a mile range on the ground. And that is going to be dependent on a couple of things. One is weather. Is it pouring down rain? If it's pouring down rain, that reduces your range a little bit. Are you in a heavily congested area with numerous buildings? All right, your range is going to be knocked down a little bit. However, yeah, line of sight. Now, if you put this thing up in the air, your receiver, get up to about 800, 1,000 feet, you now got a range of 5 to 7 miles. The same goes with the drone. Our standard SOP says that if we get into an area and we start searching, and we do the ground search and the mobile search, and mobile searches we train them how to use all of this equipment with vehicles. So you can cover more ground quickly. But if you're in that area for 30 minutes, you've covered a lot of ground. If available, we then call in an airborne asset or put a drone up because now we have increased our range considerably and get a better idea of what direction we want to go in. Now, the airborne and the drone are not designed to pinpoint the person. They are designed to get a ground team within range where they can then pick up the signal and track to the person. In the mobiles, to give you some idea, there's a magnetic antenna that goes on top of the car. As I said earlier, we get about a mile with that receiver handheld. With the mobile antenna, you're going to get a half a mile. And that's going to be 1/4 of a mile on each side of the vehicle, half a mile across. Reduces the range, but it gives you a lot of ability to cover area and do it quickly. So, is there any other questions that I can answer? Because I'm sure that if not, we're not going to make it a whole hour. I'm going through this pretty rapidly.
Well, Jean, I would like to tell folks, because most of the people on today are from East Texas. Mm-hmm. There are several counties that have Project Lifesaver, including Smith, Gregg, Marion, and Harrison. There may be some other counties also that I am not thinking of right now. But in Smith County, I'm going to turn this on, my video. In Smith County, the Alzheimer's Alliance, we are very unique, where the Alzheimer's Alliance of Smith County is the administrator of the program. The sheriff's office they're the full member agency. And we do the administration. We have volunteers that do the battery changes every 2 months. We are going all to long range transmitters that look a little bit different. What is the the range compared to the other the CS that you just showed us?
All right. On the long, we call them the long ranger transmitters. Bench tested, they're at 3 miles. However, they are subject to the same limitations as the other transmitter. Obstacles, vegetation, weather. They have an advantage in giving you more range. The disadvantage with a long ranger transmitter, as you probably have already figured out, if a case breaks, the whole thing has to be replaced.
Yes.
That is the disadvantage, and they are a little heavier than the CS transmitters we have.
Yes.
But notwithstanding, if somebody thinks that that's what is going to answer their situation, we'll certainly not dissuade them from using them. You just have to understand the pros and cons of each, and then you make a decision. If you're in an area that is a lot of open range, for instance, I trained an agency in Arizona with a 1 mile transmitter and got a 5 mile range. Why? Open land. There was nothing out there to block or knock down or decrease the signal strength. So if you're in that kind of area and you're using a long ranger, which is rated at about 3 miles, you're probably going to get a lot more. So that may be the answer to what you want.
Okay, we have a lot of trees here in East Texas. We're called the Piney Woods of East Texas, but not a lot of building structure, and some rolling hills, no mountains or anything. And Jeremy Black is saying we have too many 100-foot pines. Does that inhibit?
Yeah, anything that's going to get in the way of the radio signal, it will penetrate it, but it will decrease the range.
Yes.
So, I tell agencies, if you really want to become proficient in this, tracking these radio signals, I have learned, is a diminishing skill. You need to get out and you need to train with it. You need to practice with it. You can't pick up one of these receivers once a year and go out and you're going to be proficient. There are things that happen out there. For instance, when part of the training, we're going to introduce you to what we call ghost signals. What is a ghost signal? A ghost signal is nothing more than a deflected radio signal. Okay, what deflects them? Any building with a lot of metal in it. And I'll answer that. Body of water. Body of water will enhance a radio signal, and I'll go into that. But anything that can get in the way of that radio signal can either decrease the range or bounce it, deflect it. And we trained you how to read that, how to deal with it, and come out of it. But you have to understand that that can happen. That being said, okay, let me cover the question on water. Yes, water will enhance it. Radio signals are a lot like water. What do they look for? The path of least resistance. So if it's across a body of water, yes, it will pick it up and send it. It will pick it up. It'll go further. You'll get much more range. Now, will it transmit from underwater? Yes. Your range is going to be decreased, but we have tested them and found them when they were 12 feet underwater, 200 yards offshore. Now, how long are they going to last? That's going to depend on how well they're put back together. I've seen them last 3 weeks underwater. I've seen them last 2 hours. So that depends on, how it's put back together and lubricated to keep that water from seeping in. Because as I said earlier, there is nothing out here that's waterproof. Eventually water is going to find its way in. So I think does that answer that question? I hope.
I think it does.
So, there's good. There's one other system that we are working on. We've been working on it for about 2 years. I am not ready to put it out. I'm getting a lot of questions on it from our member agencies, and you may have heard about it. It's called the STAR system. The STAR system works on in a radio band, but it's a much different band. And it's all digital. It's supposed to be an enhanced radio signal, and there's no auditory to it. It's all reading numbers as to how the signal strength is. We've tested it. We have found some glitches. We are not ready to put it out there because my feeling is if I put something in your hands and I am not totally confident it will do the job, I will not put it out there. So any of you that have heard, well, Project Lifesaver is going to go to this star system. They got this big super duper thing they're doing with the star system. Partially true, partially. I don't know when it's going to be ready to go out. We're going to continue to test it until I can get about a 99% success rate in training and in different environments. You won't see it. And it's got a whole different transmitter, and the transmitter is solar charged, which that is great. But if the transmitter and the receiver that is not doing the job, then it's not ready to go anywhere. So.
Hey, Jean, in that, yes, I can see how that wouldn't work because a lot of people with dementia stay in their houses, and that wouldn't work with solar charging. Could you address the questions that we get all the time from caregivers? And I know that law enforcement will too, as they get into this program. Well, does it work on GPS or cell phone technology, and why not?
Does not work on either one. And I just saw the thing like low jack for people. Well, yep, somewhat, but an entirely different frequency range. In fact, low jack tried to at one time take this away from us, and it didn't work. Does not work on GPS, does not work on cell phone technology. And I'll tell you why. We have tested both. GPS has a lot of limitations that people don't understand. Yeah, you see, and I call it the NCIS mentality, because people watch NCIS, they say, well, we can track this person because they've got a GPS chip on them, and they find them in the 3rd floor subterranean basement room behind the boiler. Not happening. Not going to work. GPS signal can be blocked by anything that can block sunlight. If you have a GPS and I'm trying to, as they call, ping you, and you're in a building, I'm not going to get you unless you're standing right next to a window. If you want to see how that works, if you've got satellite radio in your car and you've got it on the satellite station, drive under something and stop and see what happens. What do? You lose that signal. So, plus GPS is power hungry. It has to be recharged intermittently. Every time that thing is pinged, it sucks power like there's no tomorrow. So you may be able to ping it for about 10, 15 minutes, and then it goes dead, depending on the type that you have. Also, GPS was not designed. A lot of people don't understand. It was not designed to locate people. It was designed for navigation. Well, in navigation, you're not going into buildings and under trees and in garages, or I found people under houses. So you're not getting under these kind of things. You've got usually open sky. When I was in the Army, one of the things we always did when we had a GPS unit was we carried 2 other things, because we knew that if we lost satellite signals, we would need a map and a compass. So we made sure that we stayed proficient on those, because quite often we would lose satellite connection. One of the things with GPS, in order to get a satellite fix, you got to have connection with at least 3 satellites. 3 satellites will put you supposedly within 10 meters of what you're looking for. Now, if you only get connection to 2 satellites, you're now at 100 meters. If you only get a connection with 1, you're now at 1,000 meters. Just think about how far out that is. And these are the things we found. It is great for what it's designed for. It is not designed for this. There's too many ways that it has got failure points on it. Cell phone triangulation. Yeah, we tried that too. We found out that it worked about 1 in every 30 times. And if you got into an area where there was multiple cell phone towers, it just went crazy. So that's the kind of success that we've had with cell phone technology. Now you can ping, we know you can ping an iPhone or those kind of things, but how many dementia patients or kids with autism are going to carry around an iPhone or carry, some type of cell phone with them, or even know how to use it? It just doesn't work out very well. I wouldn't say that if somebody thought it would work, try it, but I wouldn't recommend it. Does that answer that question? All right, is there any other questions that I can tackle out here?
Maybe about the cost, because I know we have probably several agencies represented. They do not have Project Lifesaver in their county. What about startup costs?
Startup costs for an agency with our ComSpec 3000 system, which is the one I really recommend. It's easy to use, easy to train on. It's far less trouble. Is around $4,000. Now, what you get is you get your training, which is about 2.5 days, but we not only train you as an operator, we're going to train you as an in-house instructor. That way, you can then train other personnel within your agency only, to use the equipment, and do the program. You get 2 sets of equipment. You will get 2 receivers, you'll get 2 transmitters, everything you need to start your program. We will give you all the paperwork and discs that you need. We will train you on how to do your work. We will also give you access to our portal system. The portal system will allow you to go in and order equipment, effect repairs, do after action reports on searches. It will allow you to put your clients in. You can put their history along with a picture. You can put all of your electronic search specialists, list them in there, and when they need to be recertified. The other thing it does for the clients, it will alert you on battery changes. Now, do you have to do the battery change? Well, for years we said yes. Now we say you must adequately train the caregiver to do it. And from time to time, you need to check and make sure they're doing it the way they're supposed to. So you get all of that. The only other expense is the instructor expenses to get to you and train you. So you can usually look at, $4,000 to $5,000 to start the program. But I can tell you, the average Alzheimer's search, we figured years ago, and I'm sure it's changed and gotten more expensive now, was 9 hours. That 9 hours equated to $1,500 an hour agency cost. So just do the math. We did one search in Chesapeake. The one I think I told you about, the 79-year-old Alzheimer's patient. That search in trying to figure out the cost factor for our agency came out to $342,000. So look at, if you're trying to sell it to a bean counter, use those figures and I'll be glad to give them to you. It saves money, it saves time, and most importantly, it saves lives. I got to the point when I was doing the regular searches, because I was the person in charge, I was the one that was delegated or responsible for notifying the families that, one, we were suspending the search because we couldn't find them, or we have located them, however. And that, if I'm sure some of you have been in that position and you know how distressing it can be. I didn't want to do that anymore. So when I was able to get this put together, I was very happy, and I'll tell you, once you locate my very first location with this equipment and bringing them back home and the reaction of the family, that was my deciding factor that you couldn't get me out of this program with dynamite. Just the service that you're doing to the community. I had a sheriff tell me one time, I would do this program if I only had one client. We have found out that it is one of the most tremendous public relations programs that you can do. Why? Well, for one thing, you're not going out giving talks on how to make the house safe, which is good. You're actually working and interacting with this community. And I can tell you from experience, just talking to some of the sheriffs and police chiefs out here, that pays big dividends. These people see that the deputies or the officers have compassion, they care, and that equates back to when you need it, support from the community for other things that you may want to do. So that's another factor that needs to be put in here in your assessment. You save lives, you save it quicker, use less people in doing it, and the PR benefit of the program. I don't think I could say any more that would persuade you or give you thought process that maybe this is something would be good to look into. And to look into it, all you got to do is call us. We have a website. The website is projectlifesaver.org. There's a number of videos on there, by the way, some of them from other agencies, some of them that we've done, that shows you how the system works. So take a look at that. And then if you think it's something that you would like to do, give us a call, because we will give you the materials that you need to start this ball rolling towards getting the program. And we'll help you in any way we can. We're available for conference phone calls. Whatever you need, and that we can supply, we're going to be there to help you with it. Because we know, the bean counter questions, the chief's questions, we know that they're going to come. So we want to make sure that you're prepared and will be able to answer them. So, any other questions? Thank you. I really appreciate you having me. We look forward to working with the agencies. And by the way, I know I'm probably talking to the majority of law enforcement, but we do have the program in fire departments. We have them in some search and rescue organizations that are tied to fire departments or sheriffs or police. That's one of the prerequisites. They must be aligned or affiliated with a public safety agency. The only other ones we have some assisted living. We also have about 12 VA hospitals that their police departments have this program. So there's got to be something. And then we have a lot of situations like the Alzheimer's Alliance, where the Alliance will be the umbrella and the law enforcement will be their search option, their search contingent. So we can work it any way that you want to work it. We want to make sure that you're comfortable with it.
Thank you so much, Jean and Luann. We've enjoyed this. I know that I have. And even though it wasn't a lot of new information for me, I learned something every time. And I think that's a good point, that we can all learn something new when we participate in these kind of things. And give us all a call, East Texas Alzheimer's Alliance or the Smith Alzheimer's Alliance of Smith County. We appreciate it. Thank you. Have a great day.